So I just bought my French, what was it called?
Beret.
Beret?
You missed the blue Euro football team shirt, but you can buy some of those right in the street right now.
And being an American, it's so funny to hear people call soccer football. But I'm getting used to it now. I realize that most of the world calls football what we call soccer.
But you do realize that we were here before, right?
Yes. And I have to tell you, the last World Cup, I was in Tanzania working in an orphanage, and I went into a bar, and there were two African teams in the World Cup. I think it was Ghana and another country, and to be sitting in Africa and watching those Africans go crazy, watching this, I fell in love with soccer in the last World Cup. Because when I grew up, I never saw soccer or hockey, but now you see more of it. But I feel very, very honored. So when you're talking to these Americans, about 4 out of 5, 81% are Americans. The other 19% are from 140 countries. The dentists love the podcast because they may never go to Paris in their entire life. And I'm here with a general dentist, a pediatric dentist, an orthodontist, and an oral surgeon. And it's just a huge honor that you would come and be on the show. And why don't we just start with whoever wants to start, and just tell them your name, about yourself, and what you might think is interesting about dentistry in France that somebody in China or America or Canada might not. Or
I don't have much experience in a lot of countries, but okay, my name is Jérôme Lipowicz. I'm a general practitioner based in Paris, and I think practicing in France is a huge luck, because it's a country of freedom, and we can do whatever we want, I guess. Most of specialties are not recognized, just like in the US. We only have 2 or 3 specialties.
And what are they?
Orthodontics, oral surgery, yes, and pathology, and that's it. So there is no official periodontics, there is no official endodontics, and I think for us, while it can be inconvenient, I think it's a huge luck for us, because we can do everything with no borders. So, and I like my job in France.
So some things Americans would want to know. Some dentists always say that the Mercury, and we're at the Hotel Mercury. Are we here because we're celebrating Mercury fillings? But a lot of Americans say that Europe banned Mercury fillings. What would you say to that?
No, this is not true. This is not true. Mercury is still a lot present in our practice. I don't do it personally. I never did it since the university, and there is now a huge movement against Mercury, but not only against Mercury, but for aesthetic dentistry, adhesive dentistry, and so. This is the way we ban Mercury, not for the Mercury itself, but for the alloy in general.
So there's 35,000 dentists in France. What % of those dentists still used Mercury in the year 2016?
I don't know, but I would say a lot.
80%?
I don't know, but I would say a lot, because there is no evidence about the toxicity of mercury. Okay, we know the mercury is not good, but we don't know if the alloy is not good. So many research, so many papers do oppose. There is no Cochrane study for banning, which tends to ban the mercury, and I think that it still has a lot of usages in France, because it's bacteriostatic, and many people use it because it's very easy to use. A lot of people don't use rubber dam, and that means when you think that the mercury doesn't requires humidity free, then it's still a good thing to use, and I think this is the general idea about using mercury still in France.
And you're a pediatric dentist. Do you still use it in children?
No, absolutely not. I haven't been using Mercury for 25 years now.
But you're in the Hotel Mercury.
Absolutely, but still, we're using a lot. We have a lot of demands from our patients and their parents also to move into restorative and aesthetic dentistry. So I must admit that everything that's colored feelings is really annoying for patients. So, slowly, but I'm not aware of any national recommendation banning amalgams from our dental practices.
In all of Europe?
At least in France, I haven't heard of anything like this. So it's probably, it is still in use.
And how long have you been a pediatric dentist? How many years?
25 years now.
Okay, so let's talk about two things. A lot of people say that you reduce decay with fluoridated water. But when you go around the world, Singapore does have water fluoridation, but across the street in Tokyo, it doesn't. Let's talk about water fluoridation. And in your 25 years, the question is, do you think there's less pediatric decay today, 25 years later, than when you started because of water fluoridation or because of eating less sugar? Or do you not see any change, or do you see more decay?
First of all, we don't have water fluoridation in France.
In all of France?
No, in some areas around volcanoes we have some fluoridated water, but the public health services did not do any water fluoridation programs. It was a salt program, actually. I mean, the fluoride was incorporated in the salt.
Like America does with iodine.
Exactly.
So when we wanted to prevent goiter with iodine, we chose to put it in salt.
The salt. The problem was that the packaging of the salt with fluoride and the one without fluoride was pretty much the same. So parents don't even know what type of fluoride they're using. So we use, in the past we have used a lot of supplementation, fluoride supplementation. Pediatricians used to prescribe to their, to young children fluoridation, but we had some cases of fluorosis. So now pediatricians are kind of backing off because they are very afraid of, the few percentage of cases we had of fluorosis. So we are definitely providing counseling about using fluoride toothpaste. This is something that we are doing a lot. And we are cautious about not mixing different type of fluoride, so we do not overcharge patients with too much fluoride.
So do you think, in your 25-year career, do you think that there's less decay in French children today than when you started, or would you say it's the same amount, or would you say it's more?
The research shows a dramatic decrease of cavities in France in the past 25 years, that's for sure. But unfortunately, we see a lot of children. We see a small concentration of children, like 20%. They have all the problems. They have all the cavities. So we really need to work on identifying those high-risk patients and counseling and giving, and implementing preventive procedures to them.
And what can we learn about that? Like when you go to Vietnam, everyone's Vietnamese. You go to Japan, everyone's Japanese. You go to Poland, 98% of the people are Polish. But walking around Paris, you see people from every country on earth. When you look at those pockets of people that have more decay, do they seem to be from more specific cultures? And is that culture, do you think, eats more sugars, less? Have you learned anything on what those pockets?
It's really part of education. I really think that there's been a lot of relationship between educated mothers and the way they treat their children, and that it's related, and that low-income families, have a tendency to have, more problems than the ones who are highly educated, of course. But we do see some cultural trends, of course, not bringing the children early enough. I mean, that's really one of the challenges we have in France, and I think all over the world, because I work with my colleagues in the United States, and I see they want to have the children as soon as possible, and it's very hard to see the children as soon as possible. So we see a lot of early childhood caries still.
And is that mostly from putting the baby to bed with a bottle in its mouth?
It's a mix of reasons, but not implementing hygiene right away as the first tooth erupts, we see too often children too late. We don't see them early enough.
So when should all these dentists you're talking to tell pregnant mothers, when do you want to see the baby first?
We want to see them very, very early. We want to see them at age 12 months of age.
1 year?
Months. Yes, because we
1
want
year?
yes, because we want to provide parents with all those information. We want to tell them what they should not be doing, and how to start giving the right ritual to the children as far as dental hygiene. The earlier, the better.
Does it kind of make you sad that all of this is, everything we do is preventable? That baby is not born with Streptococcus mutans. It's not born with P. gingivalis. It's not born with herpes simplex 1. It's not born with HPV. Mm-hmm. This baby would basically not even need anyone at this table until someone kisses it. Mm-hmm. And it seems like after AIDS, everybody on earth knows that you can pass germs sexually. Mm-hmm. But it seems like there is still nobody around the world talking about not kissing a baby. A baby wouldn't have to brush or floss until somebody infected its mouth.
Absolutely.
Do you think in our lifetime we'll ever see television commercials and radio saying
it's impossible.
It's impossible. So you just give up. You gave up.
No, I do not give up. I will never give up. Especially
up?
with those young children, I will never give up. But I think we really have to work very, very closely with all professionals, pediatricians, general doctors, in order to be able to ensure those children with early counseling, really. Early counseling, but how can you tell a mother not to kiss her child? It's impossible. It is.
Well,
impossible.
I noticed the French, like in America, people kiss you on your mouth, and I think it's gross. But I notice in France, everybody does a pretend kiss. They go, mwah, mwah. But in America, it'd be, mwah. And it's like, it's funny because me and my two sons have been saying the French kiss so much more hygienically. Mm-hmm. And my dream is that, every time you meet someone, you want to be nice, and they always stick out their hand to shake it, and their hand is filthy. I kind of want to just bump elbows. I wish the whole world, if you want to touch me, let's just bump elbows. I don't want to shake your hand, but I don't want to offend you, and I certainly don't want you to kiss me on the lips. But I think the French kiss the most intelligently on earth by that fake kiss to the right and left. What do you think of that?
It's a very French subject. We can discuss many hours about French kissing.
Oh, so now you're an orthodontist. So that's one of the three specialties. You said orthodontics, oral surgery, and oral pathology.
Right.
So what is it like being an orthodontist in France?
Well, it's great. It's it's a very nice specialty for us to begin with, just to work with in the orthodontic field. It's let's say the dream of every orthodontist is to have an American-like orthodontic office, which we cannot have. The first reason being that, for example, we cannot have assistant working in the mouth of patients, not even take an impression. So, for example, my staff, my employees working in the mouth of patients are all graduated orthodontists, and it's very expensive. So we can have an American-like orthodontic office, but not American-like income because of that.
Because they don't allow expanded functions.
Right.
And when a government doesn't allow expanded functions, then it makes everything more expensive.
Right.
I remember the most funny story was India banned all the tractors being sold from America from a company called Caterpillar. And the president of India said that those tractors steal jobs, and that India had 1 billion people. They didn't need a tractor. They had plenty of people with a shovel. So they sent Milton Friedman over there, who was the smartest economist from America, to talk to the prime minister. And the prime minister said, we don't need tractors because we have plenty of people. And he says, oh, well, if that's the case, take away their shovels and give them spoons. Mm-hmm. And then the prime minister thought about that for a minute and said, okay, we'll buy tractors. And the governments always try to protect the people by passing laws that makes it so expensive, then the people don't get it. So what do you think that is? Those laws have done to the price of orthodontics in France by not.
You mean the price, the fees for patients? Yeah. No, it doesn't change. It just reduces the income of the orthodontist. if you would compare with an American income. But I think our fees are basically about the same as the American fees.
So how much would it cost if I came into your office and I wanted full braces? How much would that cost?
Would you be a teenager or an adult?
No, I'd be 53.
You'd be 53.
Even though I look 23, I'm actually 53.
Right. Well, it depends. It depends on the case. Obviously, it's very difficult to answer that question. Okay. But
a standard
an
class
average price would be. I will give you my fees or an average French fee because I'm
average French fee.
Oh, okay. Well, because it's French
for French orthodontist, not a French general dentist.
4,000 euros.
4,000 euros. And
average.
Do you know what that would be in U.S. dollars?
Yeah, about 5.
So 5,000. So about the same.
Yeah,
so
that's what I said.
Yeah. So in America, the average case is about 5,000.
Yes, it's an average, right? Because
Yeah.
Paris is more expensive.
Yeah.
And Invisalign is a little bit more expensive.
So how long have you been doing orthodontics?
25 years.
25 years. And so what would you say the biggest change you've seen in your 25 years is going from fixed to removable clear
Right.
aligners?
Exactly. Yes, for
So
sure.
what percent of your practice was removable clear aligners 25 years ago?
25 years ago, it wouldn't exist.
So when did it come on the scene, and what percent of your practice is it now?
Right. It came on the scene in 2000. It was in the Chicago convention in the AAO. And I've just started my first case as soon as it came up. But let's say it's been growing in my office more and more. And now it's about 15 to 20% of my cases, which is about my percentage of adult patients.
So it's mostly for adults?
I use it mostly for adults. I don't use it for teenagers right now because I think that the technique is not efficient enough. There are teenagers who are good candidates when they are they're almost not teenagers, they're young adults, like 16 years old, someone who likes sports, who have discipline, why not? But under that age, I would have much better result with fixed appliance, for sure.
So one thing that worries dentists with Invisalign is that if I glue everything in your mouth, I'm in control. But if I give you something you can take out, you might leave it on your sink.
Right.
Do you have a compliance? What percent of your removable clear aligners do you have kind of compliance issues?
I have some, but they are really few.
And you think
Not
that's
much.
because you do good case selection?
Right, first of all, but also there are, I think, two ways of having good compliance. If you fix a high fee, because people pay for it, and if they pay for it, they want to have a result, and then they're going to wear the aligners. If we talk about Invisalign, this is one kind of way, and the other way is spending time. A lot of time with the patient, you or your assistant, someone in your office, explaining why, how, showing slides, showing the famous clean check, and visual animation. Talk to the people to enhance cooperation, compliance. But we have also compliance issues with other kind of let's say functional appliance for kids. So we have always had in orthodontics compliance issues, and it's always been a search for to have only fixed appliance.
I want to. In the United States, the most controversial part of dentistry, hands down, is when you get to occlusion, TMJ, temporomandibular disorder. Some call it craniomandibular, but dentists pretty much agree on fillings, root canals, crowns. But when it gets to TMJ, it almost turns into a religion. Some dentists think that orthodontics, you flatten out the curve of Spee, the curve of Wilson, you pull 4 wisdom teeth, 4 premolars, that it causes all kinds of temporomandibular disorders. Other people think that it doesn't. Where do you fall on occlusion? What do you think straightening your teeth does to the curve of Spee, the curve of Wilson, temporomandibular disease, you know?
That's the toughest question I ever been asked.
I'm sorry.
No,
sorry.
so,
and I know it's the hardest
you know,
subject.
it's like a question you can answer it can take you 2 hours. So I will just take 1 minute.
No. I'll say 2 hours. I want the 2-hour answer.
Let's say, statistically speaking, if you look at studies, there is no relationship between the outcome of an orthodontic treatment and TMJ disorders. This is what science shows. There's no connection. But what I see in my practice is that sometimes patients, they have temporomandibular joint disorders that they didn't have before, and they have it after the treatment. It's rare, but it happens. So my question is, would they have the same disorders without the treatment, or did it appear because of the treatment? That I don't know. But sometimes you can make a connection. You can say, yes, maybe here this is my mistake, or this is the orthodontic mistake. But I'm not sure. Honestly, I think the better quality treatment you give to the patient, the better chance you have to resolve problems and not to have some. Honestly.
Well, let me ask another.
And quality treatment means patient not necessarily being into what we call the perfect class 1, something that looks nice on the model, but patient that has harmony in occlusion and in comfort.
Let me ask another question. Some of the younger dentists, and younger maybe being under 30, they will often say amongst themselves that the older dentists in the United States, like LD Pankey and Peter Dawson, defined occlusion as more like a mechanical hinge. Mm-hmm. And they believe that temporomandibular disorders are more psychic stress. You're stressed, you're grinding, do you think TMJ is more mechanical occlusion hinge bite, or do you think it's more psychosomatic stress oriented?
It's both, definitely.
You think it's both?
It's both. So it can be one or the other one, or both. Depends on patients, really. Depends on patient. There is one relationship that has been proved between occlusion and TMJ it's crossbite and TMJ disorders. That is scientific evidence. Also deep bite sometimes, really deep bite and TMJ. If you talk about occlusion in relationship with TMJ.
You're mostly talking to general dentists, and probably, I think 81% of who you're talking to is a general dentist in America. And we don't really we get lots of education in endo from endodontists, oral surgery from oral surgeons, pediatric dentistry from pediatric dentists, but orthodontists in America don't want to share.
They don't want to share.
They don't want to show anything.
And it's exactly the same in France.
It is the same?
Yeah, it's exactly the same in France. I'm not sure it's the same in Europe, because I have friends who have the kids students in Spain, and in Spain they have a lot of training. But it's about the same in France. So you have some training, right? I was teaching I was a graduate in the States, and I was teaching the undergraduate when I was a graduate.
What school were you at?
St. Louis University.
Oh, St. Louis. Oh, interesting. No, most every single graduate, the United States graduates about 5,000 dentists a year, and almost everyone will tell you they did not do one single orthodontic procedure. Mm-hmm. They didn't do it. But anyway, the question is, patients are always asking, you tell someone they need a night guard, and they'll say, well, I'm doing Invisalign. Does Invisalign that? Sometimes you'll tell people, well, you should bleach your teeth. They say, well, I have Invisalign tray. So my specific question is, if someone has TMJ and their general dentist says you need a night guard, and they say, well, I'm doing Invisalign, is the Invisalign tray a night guard?
Your question is, does Invisalign can be used as a night guard for TMJ?
Yes.
I think so, yes. I think so. What I do observe in my practice with TMJ patients, not TMJ patients, patients coming for occlusal correction or alignment correction, and they also have some TMJ symptoms, all right? I'm telling them, listen, I don't promise anything about your TMJ symptoms, but we're going to go to the Invisalign treatment, and you will probably see a result, less symptoms in your TMJ with your TMJ problems, and this is what I'm looking at. But obviously this is not specifically designed to resolve TMJ problems.
There was an a general dentist who taught orthodontists to general dentists way back in the day when I got to school, and his name was Dr. Witzig. And it's classical in America that if you ever go to an orthodontic course, it's not taught by an orthodontist because the orthodontist won't do it. But it was a Dr. Witzig who claimed he came from Europe, or he claimed he studied in Europe. But anyway, long story short, he claimed that in Europe they do not do 4 bicuspid extractions, and that Americans do way, way, way too many 4 bicuspid extractions. And he kind of created a class of dentists who became kind of extremist, who just said, I don't believe in 4 bicuspid extraction. But it seems to me that there's maybe 25 years ago we did too many 4 bicuspid extractions. Maybe today we definitely do a lot less. But there, in my brain, there are still indications for when you have to do a 4 bicuspid extraction. Do you agree with that?
Yes. The indications for bicuspid extractions are biprotrusion, anesthetic biprotrusion, and also when you have crowding and a weak periodontium, you don't want to procline your incisors with a non-extraction. So you better extract in those cases. And also what we call in orthodontic the high angle cases, which mean long face. Long face treatment, if you align teeth when there's crowding, the teeth will procline very, very easily. It will be ugly at the end. So you have to extract in those cases. But extraction now is only 7% of my cases in my practice. Not because I'm
what
French.
Percent?
7%.
7%?
7.
Not because you're French?
Not because I'm French, because I think it's exactly the same. We followed the same curve as the United States. Exactly the same curve. So
because
there was only this old German school from the beginning of the previous century with the Frankel school will use functional appliance to expand arches. But that's the only non-extraction tendency I can see in Europe compared to the United States. Otherwise, it's exactly the same. All the French teachers, I was trained in the US, right? But for French orthodontists, the French teachers were trained in the US and came back with US training to train the French orthodontist.
Interesting. I would think since this is the land of Pierre Fouchard, the Americans would be coming here.
They're more than welcome.
I think dentistry started 100 years earlier in France before the United States, and I'm very sad that I'm in France and the Pierre Fouchard Museum is not only closed, it's closed for 10 years. Yeah. 10 years.
Were they remodeling it?
No, I mean, they just stored all the items, and it's closed since 2003.
Here, go ahead and talk. It's what?
No, we just checked on the internet that it's closed since 2003.
Oh, it's closed in 2003, so 10 years would be... Oh, it's 10 more years or 10 years?
I don't know. It's closed for 10 years.
But is it at a dental school or a museum?
No, it's not in dental school. It's in the National Board offices. And but actually, you can see many devices, old devices, antique devices in many universities in Paris.
So what would happen if Ryan and I went to the Pierre Fouchard Museum? I mean, do you think we could look through the window?
No, but I think But I think everything is closed. So there is no display anymore.
Huh. So we're now into the oral surgeon. I think I want to ask. Thank you for joining me. I think I want to start with the most controversial question in oral surgery. 25 years ago in America, most all general dentists recommended all 4 wisdom teeth to be removed because they existed. And now, 30 years, I graduated in 87, so it's 29 years. Next year will be my 30th year. Now there seems to be a lot of research coming up saying you don't have to remove all wisdom teeth just because they exist. What is your thoughts on...
That's a good question. First, I have a practice limited to oral surgery. I have also an American degree in periodontics, and I do a lot of implants. So basically, my question is very easy. I send my patient to the orthodontist, and I tell him, do I have to extract the wisdom teeth? This is the way I function.
I'm the one who has to answer.
I think it's logical.
Well,
unless there's a big infection, big cyst, things like that. Otherwise, he tells me if I have to do it or not.
The first studies showing that it's not necessary to extract wisdom teeth are from the early 80s. I was born. It's from Richardson. I think she's a woman from, I'm not even sure she's American, maybe English. Anyway, she showed that having wisdom teeth or not having wisdom teeth, the occurrence of crowding will be the same.
Exactly.
Still, there's been I can tell you, there's been a recent study that showed that people having their wisdom teeth in the mouth will have more periodontal problems on the second molars than people who don't. Because it's difficult to brush back there, and you don't masticate with your wisdom teeth, and you won't use your wisdom teeth to have bridges. So
you think it does increase periodontal disease?
it could on the second molar, from a study I've read about 2 years ago.
It depends. There is also some studies from Kugelberg showing that if the wisdom teeth are horizontally impacted, then they destroy the bone on the distal aspect of the second mandibular molar, and then you have more, three-wall defects, and then you have to do some regeneration. It really depends on the position of the wisdom teeth. But we're talking first about extraction in teenagers and in a routine way. We don't do it in a routine way, but do you have I'm speaking to my orthodontist friend right now. Do you have a way to, when you look at all your measurement, can you evaluate if there will be enough space or not?
Yes, there are ways measuring the distal of the second molar to the anterior border of the ramus, and also looking at the inclination. There is a number of degrees under which you know that the wisdom teeth won't erupt. But as I said, because of the risk of not having good brushing on the second molar, you don't masticate with your wisdom teeth. But on the opposite, what I've seen, it's true. A patient came one day. He had crowding only on the left side, not on the right side, and he had wisdom teeth on the left side and not on the right side. So it was the opposite from what I've read from Dr. Richardson's studies. And we come back to your question with TMJ. Sometimes clinically it's different from statistically reading. So
I think the best way is to evaluate each patient separately, and then we can do the measurement and see if they need to be extracted. We really try to work as a team approach, and talking with different specialties, with the pediodontist, with the orthodontist, and make the best choice for each patient. This is the way I function.
So it's interesting, you're an oral surgeon who places implants.
Yeah, because when I finished oral surgery here, I went to Southern California and I got a periodontal degree. And I was lucky enough, it was the first year where they taught at USC in Southern California implant dentistry.
So you went to USC?
Yeah.
And you went to St. Louis U?
Yeah.
she went to NYU.
I went to NYU.
And you went to NYU?
NYU, yes, I graduated.
What about you?
All these places, but just for holidays.
I got my dental degree at the University of Mercury amalgam right here in this hotel. So I want to ask you, you said you're an oral surgeon, you place implants, but you're a periodontist. It seems like the biggest failure of implants is actually peri-implantitis.
Correct.
As a periodontist, what can you tell dentists about peri-implantitis, how to avoid it, how to treat it? What are your thoughts on perio?
I think the first thing is to say to the general dentist, to the patient, that when you place implants, it's not for life. And if you want to have a good prognosis, you really have to work on the patient's hygiene, and to tell them that, if they don't brush, if they don't come on a regular maintenance, then they are going to have significant problems. And then now we have developed some protocols in order to try to prevent aging on implants. And preventing aging, it means that, we do, on most anterior cases, we do a lot of bone grafting, we do a lot of connective tissue grafting. So by doing all the things, you can prevent a little bit periodontitis, and you can prevent at least the soft tissue dehiscence around implant that are not really periodontitis, but they are like more soft tissue problem around implants than real periodontitis with infection.
I think a question they would all like to hear you talk about is, it seems to be, in the United States anyway, I don't know over here, but it seems like in the United States, we can't even get a definition on when an implant has failed. Basically, if an implant is still in place and you're still eating baguettes of bread, it doesn't matter how much blood is around it, how deep the pocket is, if it's still solid. So what do you call a failed implant, and when do you take it out?
We have to speak about failure and failing implants. It's quite
Failure
different.
and failing.
So when you start having pocket depth, separation, bleeding and probing, then it's starting to have an active peri-implantitis, and then you need to really implement hygiene and do some soft tissue management around that. And then if it goes on like that, then sometimes it depends also on the implant surface texture. Sometimes when you have some implants that do not have a great implant surface texture, you could have more infection, and then little by little you lose more bone. So basically, when we have more than half of the bone level that has been destroyed, then the best treatment is for me to remove the implant. Then it's a real failure.
There are some periodontists going around the country that are recommending that you buy a laser, a procedure called LANAP, and that lasering around periodontal disease actually is a good form of treatment. Do you think if patients have, you're a periodontist, do you think LANAP is a good procedure?
About 10 years ago, they start doing bone regeneration around in implants, failing implants with 2 or 3 wall defect. They start doing not only regeneration with just biomaterials, but also with membrane and biomaterials, doing guided tissue regeneration on implants, and the results are really not promising at all. So most of the people that were lecturing on this subject are not lecturing now. The best treatment is only doing hygiene, that's it, cleaning, and to my knowledge there's no real research showing that with laser you get I think for me, from what I've seen, it's more like a commercial aspect of trying to save the implant, but really doesn't work.
So you're saying money's the answer? What's the question?
I think so.
A lot of dentists ask, okay, so when someone comes in with peri-implantitis, or let's just say in periodontal disease, we do the cleaning, we numb up, we do root plane curettage, but some are always wondering afterwards, do you give a systemic antibiotic, or do you ever like to put antibiotic chips into the pocket?
We use sometimes some chips. Sometimes when it's advanced disease, we use some systemic antibiotic. But the best thing is really try, as my colleague said, to motivate the patient. I tell them, how you have to brush 5-6 minutes in the morning and the evening, and then you have to floss. Very few people do that. So I tell them, you can do that under your shower, you can do that in front of a TV show, but you have to spend 5 to 6 to 7 minutes. And then you have to come on recall. Some patients, they come on recall every 6 months. That's enough because they are not susceptible to gum disease or to peri-implantitis. And some are very susceptible. So I tell them you have to come every 2 months, otherwise you're going to lose your teeth and your implant. It's really, my goal is really to try, as we spoke a little bit earlier before, is to do a treatment based on each patient than giving general advices. We can give general advices, but we have to evaluate the risk factor, systemic and local risk factor for each patient. This is the way I've tried to practice.
And how long have you been doing this?
I think like my 2 friends, my colleagues.
25 years?
A little bit more. I'm sorry to say that. I came back from the US in '89.
But that's interesting because most podcasters are under 30. So you're talking to thousands of dentists under 30, and basically what he just said is it comes more down to the patient's motivation than any pill or procedure or antibiotic or chemical or something you do. It's actually...
That's why you need also to motivate your staff and your team. If you don't behave properly with your team, if you don't pay them correctly, this is good for young dentists, then you are not going to get any result. That's basic human management.
I want to ask you another question they struggle with. If an American goes to the biggest meeting, the biggest dental meeting in the world is the Cologne meeting, and it's every other year. I think this is 2016. I think it's 2017. It's usually about March, isn't it?
Every 2 years. Every 2 years. It's in March.
So it'll be March 2017. It's the only meeting on earth where you'll find 100,000 dentists from every single... I mean, there's even penguins from Antarctica at this meeting with dental degrees. I mean, it's every country on earth. But they're stressed because when they go to the Cologne meeting, there's 175 different companies selling an implant. She's 30 years old. She wants to buy one system. What would you tell her?
It's a different question. You have to look at the research. You have to look at on the implant design. It's you need at least to have a company that is big enough that is not going to be stop marketing their product 5 years down the line. It's like buying a car. It's not that easy to give an advice, but you need to buy at least for the.
Well, give her three choices. You can't. I'm not gonna let you be a politician and just skate away from the answer. I'm gonna hold your feet to the fire and say you got to give some names.
I give up because you can take all the 5 or 10 big first companies.
So you recommend the biggest companies?
Yeah.
Because they have staying power.
Because they have follow up. Because there is a good quality control. You need good quality control. I think it's important.
I agree, because a lot of dentists are asking me about the difference in bonding strength between a couple of companies. I'm like, come on, Williams Ivoclar does $1 billion a year. 3MSB does $1 billion a year. Dentsply Sirona does $1 billion a year. I'm pretty sure they probably got it right. So what you're saying is the big ones, the Noble Biocares, the Straumann's, the Megagens. Who do you think are the big ones? Who do you think are the first-class big ones
there are
that'll
two
be
things.
here?
There is first, it's like in the computer business. You have two things. First, you have I would say the size of the company, which is, of course, is crucial because you are sure that they're going to stay in business for at least a few more years. And then you have also, like in the computer business, the people who have the good ideas. This is important. I've been working with Triple I, with, of course, Straumann, with
Triple I, you mean 3i?
3i, yeah.
You call it Triple I?
Yeah, or 3i.
I've never heard that before.
And Nobel Biocare.
Where's 3i out of?
Sorry?
Where's 3i headquartered?
I think it's in West Palm Beach.
West Palm Beach?
Yeah.
So you said 3i.
Nobel Biocare,
No
Straumann,
Biocare's out of.
and
where's No Biocare out of?
It's Sweden.
Sweden. And then who else?
Straumann, which is in
Switzerland.
Switzerland, yeah. And lately we have an Israeli company or some Israeli researcher came out with the Nobel Active, which was it was created in Israel, which is I think it was quite great invention.
What's the name of it?
Nobel Active by Nobel, commercialized by Nobel. But there is a group of Israeli researchers, and now there is MIS who came out with also some new implants. MIS is also an Israeli company, and they came out with a new implant concept which is called the V3. So I think it's always interesting also to see which are the companies that come up with some new ideas that could change a little bit implant placement and perhaps implant prognosis. So I'm trying to have these two concepts.
Okay,
Big companies.
let me ask another question. A lot of people complain that oral surgeons and periodontists, they only sell Mercedes and Porsche and Audi. If you send a patient into them, their treatment plan's always $50,000. It's like all on 4, $25,000 an arch, upper and lower. But that you don't have a low-cost Chevy or Ford with mini implants, where maybe you just put 4 or 5 mini implants and their existing denture snaps down. What are your thoughts of mini implants? Some oral surgeons say real dentists don't use minis, or real oral surgeons don't use minis. What do you think of a mini implant? And do you think a mini implant is a low-cost alternative to an expensive
To tell you the truth,
Mercedes
I cannot really
Benz?
answer this question because I have no experience with mini implants. But again,
Say that again?
I don't have any experience with mini implants, so I cannot. But it depends where you stand. If you want to have a long-term prognosis, I think it's better to really stick to the research and apply the protocol that have some follow-ups for sometimes 10 or 15 years. Then if you want to give a service to some population that have very low incomes, doing perhaps some implants with not a lot of follow-up, perhaps you give a service to this patient. I agree with you. You cannot sell a Mercedes to everybody. So this is a very good point. But again, all these big companies, they also have a range of different prices and different type of implants. So I think it's also good to find in some of these companies the cheapest implant, with at least they have the same research, at least the same follow-up on the implant surface, the same quality control, and you can buy quite a cheap implant and give a good service to the patient. But at least that it's like Mercedes, you can also buy a Class A or Smart, which is also Mercedes. You don't need to buy the Class S. So I think it's better, perhaps, in my idea, to stand with some big companies that at least they have they are on business for long term, and they are not just on business for a few years to make some money and then perhaps close the company or having some lawsuit too.
Okay, I want to ask you a very important question. Lots of dentists, they see something in the mouth, and we're keep told that 50,000 Americans die each year from oral cancer. And you see something, and you I don't want to scare you and inconvenience you and say, go to the oral surgeon and have them look at that. What can you tell dentists? You've been doing this for over 25 years. What could you tell them, when they're looking at some area of tissue and they're like, should this be biopsied? Should this be looked at? Is this worth a trip to the oral surgeon, the periodontist, to biopsy this because 50,000 Americans die of oral cancer each year?
I think we can approach it in two ways. First, the way I approach it is I like to work team approach. I mean, I like to organize everything before, and then when there's a lesion that is not obvious, because the lesion in the mouth sometimes they are not very specific. So then I think it's important to be seen by an oral surgeon or by an oral pathologist, and sometimes they biopsy. So it's good for the patient. And on the other hand, if the general dentist doesn't want to send the patient right away to the oral surgeon or the oral pathology, they can perhaps take a picture and send the picture to their referral oral surgeon, and then the referral oral surgeon can give an advice, does it need or not to see the patient. But I think, again, we come back to communication and team approach. We have to speak to young dentists that are under 30, that the fact of working together, they're going to have more business. A lot of them are afraid that if they send the patient to a specialist, or if they share information with another colleague, they're going to lose the patient. That's really wrong. I mean, the more they are going to work with different specialties, the more patients they're going to get, because the patient is going to feel in a very scientific environment, and they are going to know that they don't want to do everything. I think the time that everybody is doing everything, each general practitioner is gone. I know that a lot of patients are doing, a lot of dentists are doing a lot of things, but to share information, to try to have different advices, I think it's quite important, and they have to learn doing that.
Well, 100 years ago, in 1900, there were no specialties with physicians in America. Now the physicians have 58 specialties, and we have 9. And the only thing I've learned in 30 years of dentistry is that you can't do it all. I mean, every year I practice, I take things off the menu and say, I can't keep up with that. But I want to ask you another historical question. Has oral cancer changed in your career? I mean, did it used to be more squamous cell? Is it now more HPV? Has all the talk about HPV and oral cancer, has it changed oral cancer in your career?
I mean, a little bit, but really oral cancer, the base, the high risk populations, people are heavy smokers, and also they have a high consumption of also alcohol. This is the baseline. Then there's some HPV lesion, but it's really mainly still the same population that we used to have.
And isn't that sad, because wouldn't those be your nicest patients, the ones that drink and smoke the most?
Not necessarily.
So you still see oral cancer as mostly drinking and smoking, and not so much HPV. So then I want one final go-around question. First of all, it's such an honor that you guys would come meet me. I mean, to come here and have a pediatric dentist, an orthodontist oral surgeon, and a dentist to meet me and Ryan. I just want to go around one last time and just tell me this. Some dentists, they're scared. They come out of school with $350,000 in debt. They're opening up their practice. A lot of them are just scared, and a lot of the kids routinely ask, do you think it was a bad idea to become a dentist? Because I don't know the situation in France, but in America, if you go to dental school, you're going to spend 8 years, and you're going to come out of school about $350,000 in debt, $350,000, and they're graduating. We just graduated 5,000 of them in May. There's 5,000 kids, or $350,000 in debt. So my specific questions is, do you think going into dentistry in 2016, do you think that was a good idea, or do you think that was a bad idea? And furthermore, What's got you excited? I mean, why are you burned out and fried and wish you would have became a chef? Or do you still love dentistry 25 years later? And what's got you excited about dentistry?
Well, I do have this opinion, but I change my mind every Monday morning. The question is different because in France we don't have so many fees for university.
The dental schools are free in France.
Yes,
Almost free.
almost free. Just like
Wow.
just like every studies, just like almost public studies.
So you're saying they all should have been born in France?
Yeah, maybe.
But we don't have the same quality. But we are not trained with the same quality as United States because, most of you, we went to dental school in Paris, and then we went to have our masters in the US, and it's not the same. You don't have the same kind of teachers. You're not taught the same way, definitely. So I'm not saying that American dentistry is better than French dentistry because, as you may know, you learn a lot along the way, and this is how you see things, and this is how you run your life that will make you a good dentist or a bad dentist. But still, it's not the same kind of training. So I remember when I was in the States, I would meet the chairman of the orthodontic department at 11:30 in the night, and I'd say, "You still here?" He say, "Hey, you paid for it." So this is how it works.
And that was what university did you go to?
St. Louis University.
St. Louis.
Yeah, that was Lyle
I
Johnston.
went to the other dental school in Missouri, Kansas City.
Yeah, really. Yeah,
You were in
yeah,
St. Louis, and I was in Kansas City.
yeah. So you get maybe you get for what you paid when you're in the American dental school.
So you're an orthodontist. What's got you excited today?
First of all, my experience, I wanted to go to the United States and study and have a master's degree before I knew that it would be orthodontics. Then I discovered orthodontics and I said, I want to be an orthodontist. But I didn't know my job. I never had any cavity in my life and I went to the dentist. So it was a little bit like this. Nice.
And what's got you excited about ortho today?
Today is...
What keeps you passionate and going?
Okay, I like to have... we still... in every offices you have cases that you're not happy with. And I want to have the smallest percentage of those patients whom I'm not happy with. First of all, I like lecturing. I like to try new things. And it's very, very slow in orthodontics because orthodontic companies they don't have the same money as dental companies. So there was Invisalign, but it was 16 years ago. Nothing new since then. Okay, we have 3D imaging, but that's bullshit. It's going to change really life. Micro implants is nice. And I like to try new things, and that's about it.
Some manufacturers are telling the 10,000 orthodontists in the United States that you can't be a first-rate orthodontist with two-dimensional panographs, that you need to spend $100,000 and do 3D. I get that with an oral surgeon pulling wisdom teeth, an oral surgeon placing implants, but do you think an orthodontist has to use a CBCT in order to do first-rate orthodontics?
I have a problem with the dose of radiation with cone beams. This is a real problem. I'm not really. I don't know much about it, but I know this is a problem. But it will be one day, yes, because one day we're going to be able to merge our 3D imaging from scanners, imaging scanners, and the 3D impressions and the images from a cone beam, and then it will be interesting because we can align teeth and see the roots before. It's going to be interesting, but
right now you're worried about the dosage of radiation.
Right, exactly. And we still have to prove that we will perform better treatments with association
I agree
both.
completely. In some countries, like in Switzerland and in Germany, they are very tough on radiation control, and they don't allow to take as many X-rays as we do take in the States or here, in France or in the States. again, I think the only way to be a good dentist, you have to be involved and to have some passion. You have to be involved a little bit in teaching. I mean, all of them came out of a university. They have to stay at least even a small part-time. But if you are not into a university environment and you just came out, you cannot be a good dentist. And little by little, not only you're not a good dentist, but little by little you're going to lose passion. And you're only going to look at the income, and after 10 years, you're going to be becoming for sure not a good dentist if you don't teach. That's because you go to some meetings, you just go and eat, but you don't really listen to the meeting. So for me, in order to keep passion, the only way is to teach, to be involved, to lecture if you want to lecture, but involve, and you have to stick to one university at least.
And to keep up with knowledge,
Yeah,
because
keep
things
up with
are
knowledge.
changing so drastically.
My next question is, if you were a pediatric dentist, how much champagne would you be drinking every night after work?
I admire. She's a friend. I admire her a lot. Sometimes when I have too many young kids in my waiting room, I think about my two colleagues, the two Arav sisters, how they can manage with all these kids. But I think they have a special approach.
I have to tell you, of all the specialties, I have the most respect for you because I love root canals. I love everything, but when a 3-year-old kid starts crying, I quit. How do you do it?
It's a challenge. It's wonderful. Every day is a challenge. Every day is a challenge. You see different patients. You see, and we see how dentistry.
I'm kidding.
No, we do not. We do not. We don't do a lot of sedation. We do a lot of tel shodu, and we spend time and we explain. And what's wonderful with that profession is that everything has changed so dramatically. I mean, the past 25 years, we have changed the way you were talking about 4 bicuspid and the 4 wisdom teeth. We have no more general rules anymore. Everything is personalized, individualized dentistry. We have so different dental materials now. We used to have only one dental material in our drawer. Now we have such a panel of things, and we know that in certain cases this is going to work well, and in another high-risk patient it isn't going to work well. So we can really adapt, and it's wonderful because every patient is going to be treated differently. And what's wonderful also is the team approach. I mean, working with the orthodontist, referring to the oral surgeon, that's wonderful. I mean, seeing their different approaches and the patients being, in the middle of that, and they really usually appreciate that very much.
I want to ask you a specific question. When I've lectured around the world, I've lectured in probably 50 countries now. Why is it some countries in pediatric dentistry use no glass ionomer, and other countries use a lot? Why do you see a big? Because you would think if we all went to the same college, we all read the same books, we'd be consistent. But we're not consistent with glass ionomer. What are your thoughts on it?
We're not, and I was in a convention in Tokyo 2 weeks ago, and I realized that we're not using the same dental materials we're using, and I think it has a matter to do with the companies, the way they promote their products, how they get to the university, and if students are used to using a certain type of material when they're students, they might be using it later on, it's the way the university is approaching the...
What specific materials are you talking about?
We're using glass ionomers, but we're not using. Certain countries in Europe use a lot of glass ionomers. We use a lot of dental composite. We of course use the glass ionomers, but in different situations, and it would be different from one child to the other, depending on the risk of each patient.
Well, just talking to the Americans, which is about 81% of everybody listening to you right now, Americans almost never use glass ionomer. And Tokyo was the birthplace of GC.
Yeah, no.
Australia and New Zealand use a lot of GC, and I always wondered if that was because Australia and New Zealand are the next island over from Japan in the Pacific. So talk to the Americans. Why do you use glass ionomer at all? And why do you think the Americans pretty much, I mean, GC will tell you they don't sell pretty much any glass ionomer in the United States.
I think glass ionomer really, in certain cases, it's very interesting. But I like dental composite. I trained in New York, and we use a lot of dental composite. I think a lot of European companies started the glass ionomer, and it's been very much advertised in dental schools. So I think students were using a lot of dental glass ionomer, and they still continue on using them. I think that's the way it works.
So you think glass ionomer still has a place, or not really?
I hardly use any glass ionomer.
I
hardly use them. I use them as liners. I use them, but I will never do a complete filling with a glass ionomer.
Would you say this? Going around the world, some places like London, the insurance pays you just for a unit of time. And so like in Japan, the way they pay, a dentist will spread out a root canal over 10 appointments. And in London, it's the same thing. They have 3 basic time deals. That in a lot of countries that use a lot of glass ionomer, it's because I only get to see you for 10 minutes, so I'm just going to squeeze something in to try to...
Well,
kind of almost
everybody's trying to find the perfect material. We're talking about dealing with children. I mean, if I have to wait 10 minutes for a cement to set in the mouth, it's not possible on a 3-year-old. So everybody's looking. I was in Japan. Everybody was looking for this smart material that you can just fill in. You don't have to do a few layers. You don't have to polymerize that long. I mean, everybody's looking for this dream thing. So I think glass ionomer was somehow very easy to use, very fast to use. But the mechanical properties is an issue.
Let's. This is called Dentistry Uncensored because we ask the brutal questions, and the last thing we'll talk about, we haven't talked about it before, is money. Some countries like Singapore, you buy dentistry like you buy your house, your car, and your iPhone. You just go buy it. It's there's no insurance. There's no insurance in Brazil or India. You go to some countries like the United States or England where people expect someone else, mainly the government or your employer, to pay for dentistry. So the Americans, the first thing they're going to be wondering is, France has what? How many millions of people? 50, 60 million?
60 million.
So the 60 million people, do 60 million Frenchmen say, I'll buy my iPhone with my own money, but when it comes to my teeth, the government pays for it? Does their employer pay for it? Talk about money in France for dentistry.
I think you cannot generalize.
Yeah.
I think you cannot generalize. Some people, want a reimbursement, then they go to some government dental companies and they can dental offices that they can get the treatment. Then if they want other type of treatment, they go to some private offices. I think it's like in the United States. You cannot generalize.
So there's a mix of
for instance,
government provided and...
So the reimbursement for dental implants, for orthodontics, adult orthodontics, or for our treatments, patients they don't have very good dental plan in France, so they have to pay a significant of money themselves. They have to pay themselves. It's a little bit like in America, I would say.
You'd say it's like America?
Yeah, a little bit for me.
So it's a mix of government insurance, free enterprise insurance, and cash?
Yeah.
And cash? So if 100 patients came in, well, you're a pediatric dentist, so let's go to the general dentist because this is different. If 100 people walked into your office and got their tooth fixed, what % would just pay cash? What % would have some type of free enterprise insurance? And what % would the government pay for it?
It depends if they need prosthetics. So if they don't need prosthetics, if it's just restorative dentistry, it's mandatory to apply the fees the government set. So, for example, in France, if you have a decay, you have to pay 40 euros for filling, and I don't know what is the general the average.
So the government sets the fee, but do they also pay for it?
They pay for it, and then the patients get refunded. But it depends.
So the patient would pay you.
Yes.
And then the government would refund them, and the government sets the fee.
Yes.
But that's for cleanings, exams, and fillings?
Yeah, and restorative dentistry.
And is restorative just fillings, or does that include crowns?
It does not include crowns.
Okay, so just fillings.
Yeah, fillings, and not inlays.
And not inlays. So if it's a removable, like an inlay or a crown, then what happens?
Then the government fixed a price.
The government still sets the price?
Yes, but for refunding, but the dentist is allowed to set its own price.
Okay, so the government will say the price is this much, but you can charge more.
Yes.
Okay.
That's the case for prosthetics, for inlays, for
Does the government-
for orthodontics.
Does the
for
government
young
set
kids.
the price for everything, including orthodontics, Invisalign?
Not Invisalign, not for adults.
It's all this is
yeah.
just for kids?
Yes.
Yeah, till 16 now.
After age 16, patients have to pay for their own treatment, with sometimes private insurance giving a
So the
small amount of
government,
money.
so the government only sets the fee for children,
Right.
not
Not the
adults.
fee.
Not-
Not the fee. It sets it will give the patient about 200 euros, which is about $250 every 6 months. So if the treatment lasts for 2 years, which is a kind of average time, the parents will get $1,200. That's it.
Partial reimbursement.
It's a partial. Yeah.
And the fees are set for restorative dentistry and endodontics, but not for perio, and not
Yeah,
Are you-
only basic scaling is set.
I assume since I came here from London on a train that only took 2 hours, which by the way, I thought that was the coolest thing in the world, to go to the train in London and be in Paris 2 hours later. How cool was that? But the reimbursement in dentistry on England I find very bizarre. I mean, basically they're asked to do a molar root canal for $100, where in the United States you would get $1,000. Do you find the reimbursement rate in England kind of bizarre?
Yeah. For what we don't know it, but we've always heard it was bizarre.
It's the same.
Yeah, but it becomes the same.
We almost have the same problem here, you know. Basically, the philosophy is that, you know, when you set the price with no consideration with the people who are doing the job, then of course you cannot ask a GP to do a very good root canal in 15 minutes on the molar or 20 minutes, when an endodontist could spend perhaps, I don't know, 45 to an hour or perhaps sometime 2 hours.
And if the prices do not increase for 10, for 20
Yeah.
years, the quality cannot improve.
But I guess when you talk about price controls, I guess the businessman in me says the government. What would happen to cars if the government set the price on cars? What would happen to my iPhone if the government said an iPhone could only be $100? Why would a government not set prices on houses, cars, and phones, but on fillings, crowns, and root canals?
Because the goal is to try to give a minimum access to dentistry and to medicine to a lot of people. So in fact, I mean, in France we have, I would say, I'm talking about more medicine, we can say that the level of good care is quite high and patients don't have to pay much. So on that aspect it's quite good. I don't know if everywhere they work the same way, but the level of medicine in most of the big hospitals is very, very high and people don't have to pay a lot. But on the other hand, then we pay a lot of taxes because somebody has to pay. So then we enter more into a political issue than a real dental issue.
Let's call Don.
Well, I just want to tell you guys, seriously, it is such an honor to come over to your... By the way, I've been... Ryan and I we've even been to Antarctica, so we've even seen the penguins, and I told my boys that it is just the most amazing town. I mean, it's in the United States, like in my town in Phoenix. I mean, it didn't even exist before they invented the air conditioner, so nothing in Phoenix is over 50 years old. And to see buildings that are hundreds and 200 and 300 years old, but there's no trash, there's no graffiti. It's that you could not find a city in America this clean, this cultural, this classy. I mean, when you come here, I mean, I come from Kansas in America, so even Americans consider me a hillbilly. But when you come to Paris, you realize every American is a hillbilly. You're just not going to find a city with as much culture and class and cleanliness and organization. And I mean, it is just stunningly gorgeous. Just unbelievable. And for me, from an American hillbilly to come over here and be entertained by a dentist, a pediatric dentist, an orthodontist, an oral surgeon, thank you from the bottom of my heart so much.
Thank you.
And thank you very much. I just shake all there, and but I do want to know how come I'm the only one wearing the proper French beret, and the 4 people from France notice are not.
We have changed a tiny bit now. We don't wear the beret anymore.
You don't wear it anymore, huh?
Our grandpa used to wear that.
Your grandpa? Okay, so I'm outdated again. Gosh darn, I'm the only one properly dressed at this meeting.
But we still eat the baguette, though.
You still eat the baguette?
We still eat the baguette.
Yeah. Okay. Well, again, thank you so much from the bottom of my heart.